All right. With that, let's go ahead and get started. Thanks everyone for being here. Again, happy 2026. Welcome to Emory Department of Medicine Grand Rounds. We're excited to have y'all here, as well as three incredible speakers from amongst our team. Dr. Liz McCord completed her combined residency in internal medicine and psychiatry here at Emory in 2020 before going on to become an ambulatory chief in our internal medicine residency program and was the first med psych resident to hold this position here. Following this role, she returned to training to complete a fellowship in addiction psychiatry here at Emory and is now faculty in the Department of Psychiatry. She leads the addiction consult service while also maintaining an outpatient addiction clinic and also works as a hospitalist on the Grady Med Psych unit. Beyond her clinical and academic roles at Emory, she serves as adjunct faculty for the University of California's at Irvine's Train New Trainers program, where she educates and mentors health nationwide in the field of addiction. We're also joined by Dr. Vettese, who is a faculty member in the Division of General Internal Medicine at Grady. She has extensive clinical and academic experience in pain management and palliative care, diagnosis and treatment of substance use disorders, and harm reduction. Additionally, she's been a clinician educator for 30 years, and I would be remiss to not highlight an incredible mentor for many of us across the Department of Medicine. And then finally, Dr. Carpenter is an associate professor in the medical toxicology section, Department of Emergency Medicine here at Emory. He graduated from Brown and then completed his medical school at Stanford. He completed residency in emergency medicine at the Los Angeles County Harbor UCLA Medical Center and fellowship in medical toxicology at Emory and the Center for Disease Control and Prevention. He's board certified in emergency medicine, medical toxicology, and addiction medicine. His clinical time is spent between Grady's emergency department, medically assisted opioid treatment clinic, and medical toxicology consultation service, as well as the Georgia Poison Center. He was recently appointed as the medical director of emergency medicine addiction services for all of Emory Healthcare. He co-founded the Grady Emergency Department-based Peer Recovery Coach Program in 2023, obtaining state funding to sustain this program and expanded to Emory Midtown in 2025, including take-home naloxone programs at both hospitals. In 2024, he founded the Grady's Forensic Injection Clinic, serving incarcerated patients with opioid use disorder. All right. And with that, we'll go ahead and get started. Thanks, y'all, for being here.
Thanks, Annie, for the wonderful introduction. I know all three of us are excited to be the opening act for the 2026 Grand Round season. We're going to be discussing substance use disorders in medical practice today using a case-based format. We have no financial disclosures. We hope that at the end of this session that you feel more comfortable implementing effective and safe acute pain management for patients with opioid use disorder. If you are not already prescribing buprenorphine for treatment of opioid use disorder, that we get you one step closer, that we hopefully provide you a couple new tools in your toolbox to provide compassionate care to people with methamphetamine use disorder, and that we get you more comfortable with prescribing medications for alcohol use disorder. As mentioned, we're going to have a case-based approach. If you have questions as we go along, please put them in the chat, and hopefully we'll have enough time to address all of those. So the first case is Mr. T. He's a 48-year-old man with opioid use disorder. He injects fentanyl approximately 2 grams daily, and he's been doing this for a number of years. His history includes multiple prior unintentional overdoses for which he's fortunately been resuscitated with naloxone. And he presents to the emergency department with severe neck pain. He's feeling feverish, nauseated, not looking so good. MRI shows a C3, C4 vertebral osteomyelitis. All involved decide that this is going to be a non-operative approach to treatment. His blood cultures quickly grow methicillin-resistant Staph aureus. ID is consulted, and they make the recommendations for preliminary antibiotics. And for acute pain management and treatment of opioid use disorder, you are the provider, you order morphine 5 milligrams IV Q3 hours as needed. Doesn't take long. The nurse calls you, said 5 milligrams of morphine really isn't working for this guy. He's got severe pain still. You go and examine him. He's diaphoretic. He's complaining of myalgias and diarrhea. extremely uncomfortable. So you increase the morphine to 7.5 milligrams IV Q3 hours as needed. So you've signed him out, and on the next morning, a rapid response is called because the patient was found unresponsive with a pulse. He received 2 intranasal sprays of naloxone, was resuscitated, and stabilized. Once he was stable, he admits to you that he called a friend and had his supply brought into the hospital and used because he states his pain and withdrawal weren't controlled. So where did we go wrong here? Go to the next slide. So a couple key points when we think about managing acute pain in patients with opioid use disorder, particularly in this era of fentanyl use. Sometimes we think that if we use high dose full agonist opioid pain medications, that we're going to worsen their addiction, or if they're in recovery, put them at risk for relapse, when in fact, the data shows exactly the opposite, that when people do not have their acute pain managed, do not have their opioid withdrawal symptoms managed aggressively, they are at much higher risk for poor outcomes, including unplanned discharges, failure to complete treatment plans, and importantly, an increased risk of unintentional overdose post-discharge. The other key point is that in order to control pain in patients with opioid use disorder, again, particularly nowadays, we have to use higher doses of full agonist opioids than we're used to. So much higher than people who are opioid naive or are even on lower doses of opioid pain medication. I will tell you that these recommendations are expert opinion. There are no evidence-based published guidelines at this time. And so this is, again, expert opinion. Nowadays, most of us will use short-acting full agonist opioids as the initial management strategy for severe pain in patients with opioid use disorder, as well as to control their withdrawal symptoms. And there are reasons for that, which we'll get into. Initially, I usually use parenteral full agonist opioid to get rapid control of the pain so that the patient can get more comfortable and we can have a more thoughtful discussion going forward, with the thought that I will change to oral opioid pain medications when the patient is more stable and the pain is better managed. We know from case reports from Canada where they occasionally use short-acting opioids for treatment of opioid use disorder in the hospital setting, that it takes about 300 oral morphine equivalents nowadays daily to control withdrawal symptoms in patients who have fentanyl use disorder. And so when we convert that to the opioid pain medications that we're used to, that looks like morphine 10 to 15 milligrams IV Q3 hours, or hydromorphone 2 to 3 milligrams IV Q3 hours. And again, these are much higher doses than most of us are used to providing. When I dose parental pain medications for acute pain, in this situation, I usually prescribe Q3 hours scheduled with right of refusal, and hold if the patient is sedated, so that if the patient doesn't want the opioid pain medication, obviously they don't have to have it. Likewise, the nurse can hold the opioid pain medication if the patient is sedated. And this, keeps the patient from looking at the clock over and over again, gets rid of that 20-minute delay when the nurse is getting the opioid pain medication. If you are comfortable and your institution is comfortable, depends on where you're practicing, a PCA is also a great option. And again, really gives control to the patient in terms of controlling the pain and opioid withdrawal symptoms. Oral pain medications, we're talking about oxycodone, 20 to 30 milligrams, Q4 hours, or hydromorphone, 6 to 8 milligrams orally, Q4 hours. Again, I will schedule this with parameters. And in both these cases, it's important to go back in a half an hour or so, see how the patient is doing. If there is uncontrolled pain, uncontrolled opioid withdrawal, then the doses need to be increased. So once the patient's pain is manageable and they're more functional and ready to have a conversation, the communication piece is really important, as is in all pain management. And the first thing I do is talk about goals for pain management. And so I usually approach that emphasizing functional improvement. So I might say, the goal of pain management is for you to be able to be comfortable enough to get up and go to the bathroom by yourself, to sleep a few hours, to eat, to visit with your loved ones. But on the other hand, it's unlikely that this pain will be completely resolved because this is just a painful medical problem that you are undergoing. I will talk about, yes, we will use opioid pain medications to control your pain and your symptoms. We're going to use IV initially so that we can get you more comfortable, as we did. But as soon as you're stable, we're going to switch you to oral opioid pain medications. And the reason for that is that oral opioid pain medications are safer than IV pain medications, and that they will last longer and provide the same effective pain relief. Then I will talk about non-opioid and non-drug treatments, so multimodal pain management approach. I usually will say, I'm going to prescribe acetaminophen and NSAIDs, and usually the reply is, oh, that does nothing for me. And I usually say, it has a great safety profile, just humor me and it might help, because indeed it probably will help. And then I talk about, the other non-opioid treatments. In this case, antibiotics. As the antibiotics kick in, your pain, your infection will get better, your pain will get better. Physical therapy will be here when you're stable and ready, and that will help your pain improve and your function improve as well. Then the all-important discussion about early discharge planning and assessing readiness for treatment. The hospitalization for people who have substance use disorders, and as it is for all the rest of us, are a key moment where people may be willing to engage in change and engage in treatment. And so with that, I'm going to hand it over to Liz, who's going to walk us through medications to treat opioid use disorder.
Thanks, Tracy. And just one question in the chat about talking us through how we would dose a PCA for this patient, and sounds like they need a high basal rate, and questioning of how to go about a PCA in this situation.
Yeah, so most of I assume all of our institutions have order set for PCA. Again, you want to set it at a higher dose. Okay, so you might set, if you set a 10-minute lockout, morphine you could start with morphine 2 or 3 milligrams, hydromorphone 1 milligrams with a 10-minute lockout. And again, reassess in 30 minutes. They will very likely need a higher demand dose.
Thank you. Okay, so talking about medications for opioid use disorder, and really focusing on buprenorphine and sometimes methadone in patient, I will say one of the most striking statistics that I see and have read about in practice is that less than a third of opiate overdose survivors actually receive medications for opioid use disorder in the next 12 months. And even though we know that these medications decrease all-cause mortality and opiate-related mortality, and I will say that, this case hits very home for all three of us, because this is a case that Joe and I have a patient that we took care of. I've had in 2025, I think I had 5 people overdose in the hospital under my care. So and as an addiction provider. So this is something where we need to get them on medications that can protect their lives, and we don't need to wait to outpatient. We can meet them where they're at. Many studies looked at starting buprenorphine specifically in inpatient services and starting them in the ED, really great opportunities, and Joe can expand on that, but to start buprenorphine and just get them linked to care. We know that in 30 days, patients are more likely to be in treatment. And Joe is actually going to talk a little bit about choice, which is a really wonderful initiative that he can expand on.
Yeah, so I'll just start by saying choice came to me first through Dr. Del Rio, who reached out to Dr. Vettese, who reached out to Dr. Steck, one of my colleagues, who then reached out to me. So I got to give kudos to all of those individuals for getting me to be part of this project. But Choice was an NIH-funded project that started as a retrospective review at 4 centers, of which Grady and Midtown were included, and we looked at patients admitted for injection-related infections. So that's this guy that we looked at in this case, right? We looked at over 1,600 patients over 5 years, and unfortunately, only about half of them received a medication for opioid use disorder in the hospital, so buprenorphine or methadone. And that comes in the face of some really kind of sobering data here, right? So obviously, untreated or undertreated withdrawal in this case was a risk factor for this gentleman to have an overdose in the hospital. But in a lot of cases, folks just leave. So in the CHOICE study, people that were started on medications for opioid use disorder in the hospital had a reduction in patient-directed discharge of nearly 75%. That's a huge number. We also looked at how effectively people were linked to outpatient care. People that were started on medications for opioid use disorder were slightly more likely to be linked to outpatient care. Because of some limitations in the data set, we don't know whether folks actually made it. But we also looked at some of the language that was used in the chart, and we'll talk a little bit about stigma later in the talk here. But it's worth saying that people whose discharge summaries had language that used non-stigmatizing terms, things like person with opioid use disorder rather than abuser or addict, were 4 times more likely to be linked to ongoing addiction care after they were discharged from the hospital. Next slide.
Right. Revisiting Mr. T. So he's now on step down, being monitored for respiratory depression. He's awake, he's alert, he's diaphoretic, tremulous, complaining of nausea and whole body aches with severe 10 out of 10 neck pain because he does still have osteo. His heart rate's 143 and his blood pressure is 164/101. And you ask a nurse to perform a COWS, which is 18. So how many of us, if you are brave enough to come and message on the chat, use a COWS, know how to use a COWS, have talked to a nurse about how to do a COWS, or make it part of your practice if you have patients with opioid use disorder or opioid withdrawal in the hospital? It could be 0. All right, well, what is a COWS? So it's not the animal. It's the clinical opioid withdrawal scale. And what it is doing is essentially it is creating a scale, obviously, on how we can, assess someone's opioid withdrawal and the severity of the opioid withdrawal. And it's based off of several questions that you ask the patient, subjective questions. So questions about, and some objective, but questions about their anxiety and, are they feeling anxious? But you're also looking at pupil size, sweating, yawning, goose flesh. So, skin changes and runny nose and things that indicate that somebody is in severe withdrawal. And what we do in the hospital to assess whether somebody is appropriate to start on medications like specifically buprenorphine, and we'll talk a little bit about how we do that. We want to see how severe their withdrawal is. And sometimes it takes a long time. With fentanyl, I can have patients who it takes 40 to 72 hours, sometimes longer, depending on how much fentanyl they use, before they're even ready to get to a place where they can be induced with buprenorphine. Now, I wrote here that this COWS is 8. 8 is that magic number where you can induce them on buprenorphine, which is a partial agonist used for detox, but mainly used for treatment for opioid use disorder. And if they get to 8, you're pretty much in the clear. At 12, it used to be kind of 12, but we pushed it down to 8 now. And that they're going to be comfortable if you start them on medications. It's in that kind of even mild range. We don't need to wait till they get to 36 or 24. This guy's 18. He's absolutely ready. Now, sometimes we can walk in a room, if we do this often and we see patients in opioid withdrawal and they've been on buprenorphine, we can ask them like, do you feel ready? And you can use that. Like the patient will say, yes, I'm absolutely ready. I need to be on medication. But the COWS is data that you can use. Now, the problem with any rating scale on a withdrawal, whether it be alcohol or opioid use disorder or opioid, is that there's a lot of inter-rater variability. And a really good teaching point is that if you go in a room with your medical student and the resident and the attending and the nurse, and you all do a COWS or a CEWA, which if we were talking about alcohol, everyone's going to get a different number. Now, most of the time, it's within a range, but it is kind of rating like how you are seeing this patient go through this withdrawal phenomenon. And I will say, I will make a nod on opiate use disorder. There is no mental status change in someone with opiate use disorder. Now, I always ask myself to prevent, or, when I'm teaching the residents or the fellows, you want to avoid anchoring bias. If a patient is going through opiate withdrawal, but they start to get altered, then we miss something, right? Why did they go through opiate withdrawal? Were they, what's going on? Are they septic now because they had osteo, or do they have benzos on board and they're going through a GABAergic withdrawal, which can cause you to be altered? But if the patient is confused, you need to be looking for something else. And how to start someone on buprenorphine is kind of stylistic. Everyone follows like their art of how to do it. I will say I really like this algorithm. This is from the California Bridge. They do this in California. It's got a great algorithm of walking you through how to start buprenorphine in someone, and they start it when the COWS is 8 when you have opiate withdrawal, and they actually give 16 milligrams. And we'll talk a little bit about 16. I think historically a lot of us may say, oh, we used to give 2 and then wait an hour and then maybe give another 4, or maybe give the rest of the 8, but they give a lot of medication, and I think this is a key point in this talk about how we can change our practices with buprenorphine to make patients more comfortable. And so I highly recommend looking at this algorithm at the California Bridge program. So you give him buprenorphine, you give him an 8 film immediately to make him feel better. He says he feels better in 30 minutes. He's still experiencing pain in his neck, but his withdrawal symptoms are significantly better. You then change his buprenorphine to 4 milligrams or 4-1. The 1 is a naloxone component, 4 times a day. And you, on top of that, start full agonist as needed of Q4 oxycodone 10 with a Q6 IV option, hydromorphone IV option for breakthrough pain. So and then you stop the IV option after 24 hours later, and you space the oxycodone out to 6 hours period. Now, this is not for everyone. This actually was the patient. This is what we did. The patient was very comfortable. The key point here is that at a certain level, buprenorphine will block full agonist, but no one really knows what that level is, somewhere between 8 and 16. If you go above 16, you're probably going to block most all of full agonist, absolutely. If you stay somewhere between that 8 and 16 range, full agonists still have an opportunity to compete with that buprenorphine. And this is why you want to dose it frequently, because the pain relief of buprenorphine is about 6 to 8 hours, or 4 to 6 hours, actually, depending on the patient. So what I do is I drop the dose, I don't go over 16, and I just give it more frequently, and I add on full agonist, and I say, did you feel that? Did that make you more comfortable? And I see what they respond to. And this is why I did not go over 16 in this situation. I gave him 8 to make him more comfortable immediately. He felt better immediately, because remember, his COWS was 18. All right, so then we'll go back to Tracy.
Okay. So 72 hours later, he's comfortable on his buprenorphine dosing, and your infectious disease colleagues recommend 6 weeks of antibiotics. So what is our next step? Next slide.
Any guesses?
Yes, so I'm also fortunate enough to spend half a day a week at the Ponce Infectious Disease Clinic. So I know my infectious disease clinics would want us to mention that we continue to try to get away from this concept of holding people hostage to get their antibiotics through a PICC line. And just a few things for all of us to think about. And again, our infectious disease colleagues will guide us in this regard. There is very convincing data that not everybody needs to be in the hospital if they have a PICC line receiving their longer-term antibiotics, and that many people can be successfully managed with home OPAT IV antibiotics in a PICC line if they have a reliable place to go and social support, and particularly if they are treated with medications to treat opioid use disorder. There is obviously good oral therapy now that is just as good as intravenous therapy for serious injection-related infections. And one of the infectious disease doctors commenting now, long-acting intravenous antibiotics that can be dosed every 2 weeks. And Joe, do you want to just mention this ID addiction clinic?
Yeah, I'll just say that the choice project we talked about earlier turned into a prospective RCT, and some of you may have seen your patients enrolled in Choice Star. So the intervention that we're studying in the Choice Star study is this combined infectious disease addiction clinic. So it's myself, Elena Steck, Dr. Fujita, Dr. Roque Gardner, and Dr. Kandaya. And basically, we'll combine an addiction provider and an ID provider in the same room at the same time, trying to break down any barriers and make it as easy as possible. Because in the past, we've had a lot of folks that presented for their follow-up post-discharge, and they only made it to one of the two, right? Especially at Grady, the ID clinics down at Main Grady, the addiction clinic is up at 10 Park Place. And yeah, they're just 4 blocks apart, but that 4 blocks can be 1,000 miles. So we're doing our best to see if getting people in the same place at the same time can improve outcomes and decrease rehospitalizations.
That's terrific. All right, so some tips for discharge. So no matter what, whether the patient has an unplanned discharge, which we used to refer to as against medical advice, and now unplanned discharge, or planned discharge, you need to be prepared. That means making sure that the patient has naloxone with them when they leave the hospital. Grady supplies this to patients at discharge with no charge. Emory and Liz and Joe's addiction clinic have harm reduction vending machines, as does Georgia Harm Reduction Coalition, all free naloxone. So naloxone. It's important that the patient, if it's a serious injection-related infection, as mentioned in the previous slide, that antibiotics are in the patient's hand by whatever means necessary. And again, that treatment for opioid use disorder has been discussed and started if that is in the patient's desires, and a linkage to post-discharge follow-up care.
Joe, do you want to add anything about the grant for the naloxone?
Yeah, I mean, I'll just kind of say it's a bit confusing on how to provide the grant-funded naloxone at Grady and Midtown. If you have any questions, you can just reach out directly to me or to the links up peer coaches. The trick is that to do the take-home naloxone, it's actually an inpatient order that gets the box to bedside rather than a discharge order to the pharmacy. And part of the reason why we did that is that we've seen in ED-based studies that if you provide a prescription for naloxone, even if it's free, the fill rate's about 1 in 7. So this gets it to bedside, and then in people that I'm worried are going to leave by patient-directed discharge, I usually ask the pharmacist to get it up there early, so that it's there bedside and they just grab it with the rest of their stuff if they decide to head out the door. And then just a word on linkage to post-discharge follow-up care. I think this has been the thrust of a lot of my efforts over the last few years, getting the peer recovery coaches into the hospital, and it's probably where a lot of you get really frustrated with me because they might be prolonging length of stay in a lot of cases, but they're really doing a great job getting folks linked to care. Right, we've talked a little bit about the clinic at Emory, Addiction Alliance of Georgia, the Emory Addiction Center, and the Grady Medication-Assisted Opioid Treatment Clinic. But that's just scratching the surface and along with GHARC of what's out there. And so the peer coaches have linked at this point to like 80 different residential treatment centers in the state of Georgia and beyond. There are a lot of community-based resources out there, and it is impossible for any physician to pretend that they're going to know every single one of those. So it's great to have folks that are doing really intensive linkage available to us, and I encourage you to avail yourself of that resource whenever you can.
Yeah, I think I speak for most of us, Joe, that it's been a wonderful, wonderful addition to our care at Grady.
Yeah, and in Midtown, they're amazing. They're all incredible people who've lived recovery. I will say Wendy asked about the vending machine. So this is AAG's little baby. We started planning this maybe 4 years ago now, 3 years, 4 years ago with the addiction training team over at Emory. And we have one at our center at the AAG on Clifton Road, which is the old Wesley Woods, now the Addiction Center. And we have one in the EUH-ED. So right outside, like kind of right when you walk in by the valet, it's free. Everything is free. It includes naloxone boxes, RX destroyers, so you can dispose of old medications, and fentanyl test strips. And those are stocked by AAG and grants and lovely donations. And we would love to have them expanded to Midtown. We're working on that. Joe's helping with that. I will say it's an expensive adventure, but so incredible to be able to offer patients these things with the vending machine. They're really neat. They are really cool. So come on by. Yeah, come on by and to the center, text me and I'll show you around. We're also building out this whole adolescent section, which is really, really nice. So anyone's welcome to stop by.
I think we missed a question in the chat on suzetrigine or Journavx. I guess I'll just say that it sounds exciting, but the evidence to support it isn't there yet, and it's super expensive. Dr. Schenker from orthopedics and some of her colleagues and I have met with the manufacturer a few times trying to get some funding to support a pilot study, and we're interested in it. But I think right now the approval is for acute pain and bunionectomy and tummy tucks. So definitely we need more evidence.
All right. Case two.
Alrighty. I think this is me.
Yep.
Alrighty. So this is Miss J, and all these folks were at least based on real scenarios we've seen. So you're admitting a 29-year-old woman with an unknown medical history. She presents to the ED after an overdose. She is found by a bystander with a needle in her arm and receives naloxone. On arrival to the emergency department, she's somnolent and has recurrent respiratory depression requiring a naloxone drip. She's subsequently admitted to the hospital for ongoing care and monitoring. The urine drug screen is positive for fentanyl, amphetamines, and cocaine. Go to the next slide. And like a good Grady patient these days, she boards for a day and a half at the emergency department and becomes quite irritable. She admits to having a history of depression and acknowledges that her drug use could lead to her death at any time. That being said, she asks for the doctor. The nurses are paging UQ 10 minutes because it is time for the patient to go. And she says, I'm depressed. I know I could die, but I would never kill myself. Please let me know. Please let me go. And we hear some unfortunate disparaging comments from some folks on the team. So you can go to the next slide. So what we wanted to emphasize here was the potential suicidality of some of these folks. We often assess people in the emergency department post-overdose when they are breathing on their own again, but they're probably still intoxicated. They are not having a clear sensorium. They don't have a clear mental state. And we are probably not doing a good enough job assessing for potential suicidality. A lot of folks are tending to assume that overdoses, especially what we might call a recreational drug or illicit drug overdose, were people that were trying to get high or trying to treat their withdrawal and simply use too much of the medication. The truth from this survey here is that there's actually quite a few people that are actively suicidal that we're missing. And way more than that, there's this ambivalent state where folks just say, if I die, I die, and I don't really care about it. And really, we need to be doing a better job asking these questions and really asking these questions at a later time point, not immediately after the patient wakes up. Because we know this can be associated with ongoing suicidal thoughts or self-harm actions. And on the next slide, this is a framework that we put together with myself and Matthew Dernbach, who was one of our MedTox fellows who did his primary residency in psychiatry, and then Randy Smith, one of our amazing trauma surgeons. And so we tried to apply the trauma survey to the post-overdose survey. And the reason why we were thinking about this is because in the trauma survey, we do our initial resuscitation in the bay, but then the trauma team goes back and does a really detailed head-to-toe 24 hours later, where they're reviewing all the imaging, they're talking to the patient again, they're doing a repeat, really thorough physical exam, and they're looking for missed injuries. And I think when we see some of these post-overdose folks, we tend to miss Some of the things like suicidality, depression, or other mental health issues, right? We're focused on opioid overdose, naloxone. All right, they've been off the drip for 4 hours, they're safe. Let's think a little bit about medication treatment for addiction, give them some Narcan, and then get them on their way. But this framework really suggests that we need to do a more thorough head to toe on their mental health once we get them out of that acute post-overdose period. Go to the next slide.
Yeah. Okay, so she is in withdrawal. Her CALS is 13. Remember, we talked about that 8. You gave her 2 films of 8-2 buprenorphine, so that's 16 total, which is a completely appropriate dose for someone who's uncomfortable and doesn't have any contraindications to getting buprenorphine. She feels much better, and she's willing to discuss what treatment options exist for her. So she no longer wants to leave, potentially because she was uncomfortable and she wanted to fix that at all costs. She wants help with her methamphetamine use because she did have an amphetamine positive urine drug screen, and she wants to know if buprenorphine helps with this or if there are other medications available. So unfortunately, obviously, you say, methamphetamine is a tricky one. So stimulant use disorder in general. So there's no FDA approved medications for stimulant use disorder. There's no medications that have shown robust evidence for helping with methamphetamines and stimulants. And before we talk a little bit about what we could do for her for stimulants, I want to just highlight here that going back to buprenorphine, in the age of fentanyl, we are underdosing our daily dose of buprenorphine. Oftentimes 16 was something that we had that kind of was our not max dose of buprenorphine we give in a day in divided doses or all at once, but we're finding that because we have so much fentanyl in our supply, heroin is very rare. Anytime I see heroin, it's like, shocking to see it anymore. But we really should be pushing towards 24 milligrams at a baseline, because this study showed that individuals who were getting 24 stayed in treatment and were still in treatment over several months. And there are individuals that I've used more than 24, 32, I've gone a little bit higher than that in very, very rare instances. I will say one of the biggest barriers is insurance. Insurance does not think that anything above sometimes 16, but mainly 24 is appropriate. So you will have a very hard time getting someone to 32 and having insurance cover the buprenorphine, unfortunately. But I have colleagues in California. I do a lot of work in California. They use 60 daily. So we don't know kind of where, we're building the plane as we fly it, but we know that we can be doing more for buprenorphine and the dosing in the age of fentanyl. So let's go back to stimulant use and what can we do? So I said there's really no medications. There are some, I think a lot of us in the room might say, well, what about Wellbutrin and the naltrexone injection and that study? And what about mirtazapine for MSM, HIV, trans individuals or cisgender who have sex with men? Yes, they have some evidence. I have had a fair response, and fair in stimulant use treatment is like maybe 1 out of 10. That's actually what a lot of the data for stimulant use medications like mirtazapine or that combination of bupropion and the naltrexone is about 10%. So 1 in 10 individuals. But really, we know that this gold standard, you cannot talk about stimulant use disorder if you are not talking about contingency management. So what is contingency management? Essentially, it's voucher-based rewards, reinforcement of changing behaviors. We've all done contingency management. If you ever got a gold star when you cleaned your room when you were a kid, that is contingency management. That the star, the reward of a changed behavior. So it's all based on operant conditioning. It is, it has a number needed to treat of 3 to 5. Now, when we think of numbers needed to treat in medicine, some of the most robust medications that we have that have the best data, their numbers needed to treat are somewhere, like 20 and above. We have an incredible numbers needed to treat for contingency management. One of the biggest issues is how do you get the contingency management for patients in inpatient and outpatient, and that's where we really struggle. California and some other states actually have contingency management covered by their Medicaid. Georgia does not have Medicaid expansion, and thus we also do not cover contingency management. But it costs about $1.28 per day for patients to be in contingency management programs. I have had patients tell me who use meth, they say, I would absolutely, if you could, I would quit meth for more money, to be able to have a phone, to be able to have, these XYZ resources that I don't have. And they have a lot of self-efficacy to do that. Cognitive behavioral therapy is also another therapy that we see pretty good responses in stimulant use with methamphetamine and cocaine use. And a lot of the studies with those medications that look like they're panaceas, they have CBT or contingency management as an arm or combined. So you have to look at those with a little bit of a microscope. And I just want to shout out, this is Dr. Aisha Appa. She is in San Francisco. They do contingency management inpatient. This is like a dream of mine. I think this would be really, really amazing. What they do is for patients who are on long-term antibiotic therapy, who can't leave the hospital for XYZ reasons, or not leaving the hospital, but are, have stimulant use disorders or opioid use disorders, they have a contingency management program where they have a fishbowl, and patients can pick out of the fishbowl and get a prize or just a verbal reward. And they had really great responses to this program, and they still do it out there in San Francisco. And back to Jill.
All right, I'll do my best to not embarrass Dr. Vettese with this one because she's really the expert here. All right, so harm reduction is obviously crucial. Unfortunately, under the current administration, it is undergoing some curtailments and restrictions in funding. So, right, we know that a lot of folks are going to go on to continue using despite our best efforts, and we want to decrease the chance of harmful effects of that use until they're ready to engage in treatment. And that's really how I phrase it with patients is you might not be ready today, but here I'm going to equip you with some skills to keep you safe until you are ready to engage in treatment. And so syringe service programs have been tremendously effective in decreasing, especially some of the transmissible bloodborne pathogens associated with injection drug use. So mainly HIV and Hep C, as well as decreasing injection-related infections. At the moment, there's been a real decrease in the availability of those services locally. I really hope that we don't see a rebound in the rate of injection-related infections, but we really need to start being on the lookout for that. We talked a little bit about naloxone distribution. I think it's important if you're going to be distributing naloxone to do some basic bedside teaching. And it can be as easy as a 3-step thing. And the lay responder training is lay, spray, and stay. Right? If you have a patient that you think is suffering an opioid overdose, you lay them down, try to open their airway, the head tilt, chin lift, spray the naloxone in their nose, spray it back, not up, and then stay, right? You don't want to just spray and run away. There are lay responder and Good Samaritan laws that are in effect in Georgia, so you'll be immune from prosecution. And make sure that folks know that one dose may not be enough, right? Some folks might need a couple of doses or more to reverse respiratory depression, and some folks may wake up and then have recurrent CNS and respiratory depression minutes to an hour or more later, requiring additional dosing. In the CHOICE study, I don't have the exact numbers in front of me, but our screening rates for HIV and Hep C were pretty poor on the inpatient side, despite us being the place that was doing the study. So, anybody that's injecting drugs, we should be screening them when they're admitted with an injection-related infection. We want to offer them PrEP. I think more and more the barriers to PrEP have gone down, and the Grady PrEP team has just done an incredible job breaking down all the barriers to that, especially now with the addition of some of the long-acting injectables. And so we are pushing harder and harder for that in the inpatients and with our patients at the Moog Clinic. We can talk to folks about safer injection techniques, things like not licking your needles, rotating sites, using sterile water, things like that. When I talk to folks about harm reduction, we don't have any supervised injection sites that I'm aware of here in the state of Georgia that are officially sanctioned. But, basic harm reduction principles of use the smallest dose possible, basically a test dose, especially when you have a new batch of something, never use alone, so that if you do go down, there's somebody nearby to give naloxone and call 911, and then, of course, have that naloxone nearby. Safer supply programs are obviously quite controversial. But I'll tell you that in Switzerland, the third line agent for treatment of opioid use disorder is a medication called diacetylmorphine. Does anyone know what that's probably better known by? Yeah, so it's heroin.
Heroin.
And so, yeah, they call it heroin-assisted treatment in Switzerland, and it's actually quite effective for folks. It's not the first line, it's not the second line. They still use the same medications that we have. But folks can do well in a very closely and tightly monitored situation. And then, of course, medications for opioid use disorder. Right? I have come to operate from a framework of if a patient asks me for buprenorphine, unless they have a history of recurrently diverting it or otherwise being abusive towards our clinic staff, they're going to get it, right? Even if I'm a little bit hazy about whether or not there's truly severe opioid use disorder there, I'm going to give buprenorphine if they ask for it. I see a question about fentanyl test strips. Yeah, it's a great question. So the drug supply in Atlanta right now, if we talk about the opioid supply, there is no heroin. I looked back at our urine drug screens from our clinic last year, and these were ones that were sent to a reference lab in California for LC tandem mass spec. We had one sample last year come back positive for heroin. So pretty much everything is going to be positive for fentanyl. So what is it useful for, in my view, is people that are intending to use something other than an opioid, who are concerned that it might be adulterated with fentanyl, right? So in this case, meth, cocaine, and increasingly MDMA I've seen with fentanyl adulteration. So very useful for those folks if they're trying to avoid opioids. Next slide.
Tracy, did you want to add anything about JHRC?
Yeah, I'll just put in a plug. So Georgia Harm Reduction Coalition is Atlanta's and the surrounding areas a major harm reduction nonprofit, and we offer all the services that Joe reviewed. Our Atlanta center is on Joseph Boone Boulevard. It's called the Bennett Center, but again, we have them sort of all over the suburbs as well. And where you serve mainly people who don't have insurance, and we are grant funded, as Joe mentioned. And for the time being, we are able to supply and treat people with buprenorphine who have no insurance. And so if you encounter patients with no insurance, this is a wonderful place to send them for treatment.
Alrighty. Mentioned this a little bit with Choice, but NIDA for a while now has had this campaign that they call Words Matter. We're really trying to talk about using non-stigmatizing language or neutral language. And for the most part, what we're talking about here is person-first language, right? We're not calling folks a drug user, we're calling them a person who uses drugs. And more than anything else, we're trying to decrease any sense of judgment and just label substance use as what it is, which is using drugs. We don't want to say things like relapse, we want to say return to use. Importantly, because when we say relapse, it implies that all the progress that somebody may have made during their prior course of treatment is lost. And really that's not the case, right? Some people like to use the term setback because that's probably a little more well aligned with what's happening there, right? You've just lost a little bit of progress, but you're not starting over from scratch. We try and avoid talking about drug screens in terms of clean or dirty, and instead just call them their medical terms of positive or negative. And then a person it's a little controversial as to whether or not we would say in treatment or in recovery, but generally I prefer in recovery because that implies that somebody is making some steps forward in their journey. Liz, any other thoughts on that? Your computer froze, sorry.
Oh my gosh, yeah.
Yeah, we can go to the next slide. Okay, yeah. So similar to some of the stigmatizing language from the last slide, when we're approaching folks and really asking them about the care that they're seeking, I think it's important that we be empowering towards the patient and really help them navigate their journey. Our goal is to sort of offer the potential options out there and help them to choose from that menu. My goal is not just to say, hey, we're going to put you on Suboxone, we're going to see you in clinic, that's it. So really just keeping a conversational tone and asking folks, hey, how did you get here? What is the current status? And what can we do to get you the next step? And if you're not ready for that next step, let's talk to you about the things we can do to keep you safe until you're there. Let's go to the next slide. All right. So let's go to our last case here because we're coming up on time. So Mr. P is a 67-year-old gentleman with HFrEF, type 2 diabetes, and CKD3. Just for fun, he's probably on a DOAC, which is why he's been hospitalized 22 times this year for falls and trauma activations. However, at this point, this is the first time he's ever come to the TOC clinic for follow-up after he was discharged from Grady. Today, his husband's encouraged him to talk to a primary care provider about his drinking. When you ask him about it, he tells you that he drinks 10 beers most nights of the week, except on football season. In football season, he steps it up a bit and has about 16 beers on Sunday. But after the season ends, he cuts back to 10 beers a day. He drinks and drives on occasion, but it's only a few blocks from his friend's house. And at this point, he really has no interest in cutting back. He says it's never been a problem, and I'm only here because my partner told me to be here. So when you hear us on the inpatient side talking about medications for alcohol use disorder, our first line treatment is usually going to be naltrexone. And so what's naltrexone? To really, really oversimplify it, it's long-acting oral naloxone that's well absorbed. It's an antagonist at the mu opioid receptor. It has some mixed effects with some agonism at the kappa receptor, which is maybe how it decreases the reinforcing effects and the cravings for alcohol. I'm going to wave my hands and give my favorite toxicologist explanation, which is that the mechanism is poorly understood. But given that it's an opioid antagonist, the biggest contraindication in my mind is anybody that's on opioids or anybody that could be at risk for precipitated opioid withdrawal because of use in the last 3 to 5 days. It has many evidence-based effects, including reduced return to use, reductions in heavy drinking days, so really those problematic days that could lead to long-term health consequences and physical injury, as well as cravings in healthcare utilization. It had a black box warning for quite some time about severe liver disease. And it was recommended that you not give it in severe liver disease. And what did they mean by that? And what does this really meant is people with truly decompensated cirrhosis and people with true acute alcoholic hepatitis. That being said, what is driving that in most cases is alcohol use, right? So there's been further study that's shown that if you have somebody whose AST is like 150 because they've been drinking, you can start this medication safely. And what's going to happen in those folks is they're going to have reductions in drinking and their transaminase levels are going to improve. So they just need to be monitored closely. And just, the real contraindication is those folks with severe decompensated disease. Usually we'll start it at a half dose for the first 2 nights and then go to 50 milligrams thereafter. The oral form is on formulary at Grady and Midtown and EUH. The injectable form is only on our outpatient formulary. The injectable form costs about $1,000 a month, though there is a patient assistance program available from the manufacturer that can tremendously decrease that cost and get it potentially for free, I think. It has been studied, from the ED and the inpatient side, both the oral and the injectable forms. And so, this patient had been in the hospital 20-something times. There was an opportunity to break the cycle there that we probably could have jumped in on. So both PO naltrexone and the injectable version can be started for alcohol use disorder. And in this McGain study that's cited here, there was a 40% reduction in those heavy drinking days, the potentially harmful days, out to 30 days. There was a decrease in ED visits, and I have a star on the hospitalizations here because most of the people in their study just had 0, 1, or 2 ED visits. But when they broke it down to those high utilizers, which is what this gentleman was, they actually saw a substantial reduction in hospitalizations, especially those due to alcohol use. All right, now it's Liz.
So a couple of other medications that we use for alcohol use disorder, acamprosate. Joe just got acamprosate on formulary at Grady. It's not on formulary at Emory and inpatient, but available outpatient. Sometimes I would say a Carpenter is very hard to find. You also have to take it 3 times a day, and the dose is 666, which is just satanic. Like sometimes I tell my patients, just if you can take it twice a day, that is fine. If they can find it, it's on kind of a national back order. Then gabapentin. I use a lot of gabapentin. The day that gabapentin is scheduled in Georgia will be a sad day for me. But essentially, not only do I use gabapentin because it helps reduce heavy drinking days, but you can see improvements in sleep and anxiety. And I use it to treat that mild to moderate withdrawal that doesn't have a history of seizures. I dose it, it's kind of 300 3 times a day. If they can tolerate it, you can go kind of 600 is on the low end when you look at all the studies, and pushing that into divided doses up to 1800 did pretty fairly well. So those are 2 options that I use, inpatient and outpatient. And then our last slide, because I had to, GLP-1s, I think if you would have asked me like kind of 2 years ago, did I drink the Kool-Aid of GLP-1s for addiction? I probably would have said, not only for a certain person, but I have converted. And I will say that I am seeing a pretty impressive response to patients who are obese or highly motivated individuals on GLP-1s who have an alcohol use disorder, a reduction in their weight, also a reduction in their use. There are some studies that looked at it for opioid use disorder. I have not used it for opioid use disorder, but they saw a reducing in opioid overdose risk. So not a linkage to treatment, because remember, medications for opioid use disorder are always and will always be the gold standard. We should not be using them for opioid use disorder, using GLP-1s for opioid use disorder. But alcohol use disorder, I'm seeing some impressive response. It is being looked at for tobacco, cannabis, stimulant use disorders. In mouse models, we see a reduction in use and self-administering those substances. And there's several trials coming out about tobacco and cocaine and opioid use disorder using semaglutide or GLP-1s with buprenorphine. So definitely on, the horizon. I think we're going to be seeing a lot more use. Will they ever be FDA approved for addiction? I don't know. I think I'm a little bit skeptical about that, but there is a decrease in reward, similar to what we see in obesity, that rewarding with food and just that reward pathway that GLP-1s work on. And it's pretty exciting to see. With that, we've listed some contact numbers, and if we have any questions, let us know. We're here in all hospitals.
Thank you, Dr. Vettese, McCord, and Carpenter. This was fantastic, and we are really grateful for this thorough review and just a really nice case discussion. I know you all have done a great job of responding to chat questions in real time. Does anyone else have any additional questions?
A lot of accolades. We appreciate y'all being here, and
Yeah, absolutely.
important work. We love what we do. All of us, I know we love what we do. So we appreciate y'all engaging with us.
Certainly a great start to our 2026 season. All right. Well, it looks like we don't have any questions in the chat. Dr. Agarwal, can you explain when to use buprenorphine microinduction in the hospital?
In 30 seconds or less. I will say I do this a lot. I do microinductions a lot because I do a lot of pain management, perioperative pain management with the pain service at Midtown, and I use microinductions to, if someone's not ready for an induction, their withdrawal is not severe enough, and I want to rapidly get buprenorphine in their system without precipitating withdrawal, and I use it if they already have high amounts of opiates going into a surgery, and I don't want to cause any, impact on those full agonists. But yeah, you can always ask me more questions. It's a little bit nuanced, but I microinduce a lot with IV buprenorphine a lot.
Any sense if we'll be able to outpatient prescribe IM naltrexone? I've been told it's MAOT only.
She might know. And Jennifer Lom, for a while back, they asked about that, and I thought that they were getting that at the AED clinic.
Yeah, it looks like Dr. Lom and Dr.
We're working on it. Yep.
Yeah, Because
There you go.
I know I was at the P&T committee meeting where I'm pretty sure it got approved. So
It's fantastic.
Awesome. All right, y'all. Well, thanks everyone for being here. Thank you again to our incredible speakers. We look forward to seeing you next week at Department of Medicine Grand Rounds. All right. Have a great afternoon, y'all.
thanks, y'all.